Hello everyone, my name is Dr. Seth Carter and I am a geriatric and family medicine physician at the LECOM Institute for Successful Aging. And today we will be talking about partnering with hospice agencies in skilled nursing facilities and personal care homes. To provide some background, let's first discuss the hospice philosophy. To better understand what hospice is, let's discuss what palliative care is. The U.S. Department of Health and Human Services and the National Quality Forum took some time to define what palliative care is, and they stated that palliative care is patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. So it kind of has that focus on alleviating suffering and helping those who are at the end of life, helping them to be comfortable. Palliative care, they also stated, palliative care through the continuum of illness involves addressing physical, intellectual, emotional, social, and spiritual needs, and to facilitate patient autonomy, access to information, and choice. Basically, it's an approach to end-of-life care that recognizes that that person has the right to have their needs met, whatever those needs may be, and not just physical or health needs, but other needs, social and emotional, spiritual needs. And they also have a right to make decisions for their end-of-life care that they no longer want to pursue treatment, but want to pursue comfort and to die in a comfortable manner. Now, hospice, what it is a specialized form of palliative care that's actually a commercial insurance or Medicare benefit. And because 90% of hospices are Medicare approved, really it's most of the time I just tell people it's a Medicare benefit. Most patients are on Medicare that receive this benefit. And what hospice does is it takes that palliative care approach and gives it a structure and creates a interdisciplinary team to provide that palliative care. Hospice is considered to be a model for quality, compassionate care for people facing a life-limiting illness or injury. There's a lot of standards, and there's national organizations that provide guidance and research to help drive the way that hospice provides this care and these services. Typically, hospice there has to be, not typically, but there's an agency or a program that provides this service, and it does so at whatever location the patient decides, whether they decide they want to pass away comfortably at home, in a nursing home, or in a hospital, wherever. The goal of hospice is neither to hasten nor to postpone death. So the treatments, the palliative treatments that are provided and the services that are provided should never shorten the patient's life, right? So the medications that are given, and again, the treatments that are given should not shorten the patient's life, and it also won't prolong their life. And hospice also provides support to family members after the patient dies, through bereavement support. And that's up to 13 months after the patient dies. The agency will continue to reach out to that family, provide support, and follow up, see how they're doing, get them counseling if they need it. And I love this quote by Morelli, who said in 2018, "At the center of hospice is the belief that each person has the right to die with dignity and in comfort." So hospice is an interdisciplinary team, and we'll talk about who makes up that team. Typically, a patient who is on hospice will have an attending or primary care physician who makes decisions on how to treat or medicate the patient to reach those hospice goals. An attending physician is not required. Some patients don't have a primary care physician or don't have a selected attending physician, and they elect to have the hospice medical director or hospice physician manage their care. And sometimes there is an attending physician who will defer hospice management to a hospice physician or medical director. The hospice medical director and hospice physician will collaborate with the attending physician, if there is one, for the palliation and management of the end-of-life care. Each patient will also be given a nurse case manager who is an RN who assesses the patient and family needs, implements orders from the physicians, and manages the care plan. He or she will go into the home, and they're trained to evaluate what the needs are, or I guess it's not just the home, but go into the skilled nursing facility or the personal care home, wherever the patient is at, and will evaluate the needs of that patient and provide that feedback back to the hospice team to see how we can provide services for that patient. The hospice team also includes a social worker who provides emotional support, counseling, and resource identification. They oftentimes will identify needs through a financial assessment and planning, facility placement. So sometimes if the patient is at home and the family can no longer meet the needs of the patient to keep them comfortable, then a social worker can find a facility for placement. Funeral planning, and they also address family and caregiver concerns or burnout. Another member of the team, of the hospice team, is a spiritual care counselor who provides non-denominational spiritual care services, responds to beliefs, customs, cultural background, religion, and desires. Hospice teams also have bereavement counselors who provide bereavement counseling to loved ones after the patient's death. They will periodically reach out to the family members by phone and see how they're doing, and if they need counseling, provide that counseling. Hospice teams also have a dietary counselor who assesses dietary needs during the end-of-life care. Hospice teams also have an aide who can develop a relationship with the patient and family, facilitate ongoing communication between the family and hospice team, and assist with personal care, activities of daily living, toileting, and ambulation. And then finally, because hospice initially started off as a volunteer organization and was largely driven by volunteer work, the current codified hospice agencies that's written into law has maintained that requirement of at least 5% of the services provided by the agencies should be provided through volunteers. And volunteers can provide unpaid administrative or direct patient care support. So what's the difference between hospice and just palliative care? So again, hospice is an insurance benefit, mostly through Medicare. where palliative care is not specifically paid for by insurance. Obviously, medications can continue to be covered by insurance and things of that nature, but other things may not be covered by insurance, such as the aids and a nurse and everything. Those things would not be covered under palliative care, and so that's where hospice has the benefit. Hospice is also implemented by a specific hospice agency or program where there's no associated agency or program under palliative care. Any physician can coordinate palliative care. Hospice is subject to limitations as codified in law, whereas palliative care is more liberally used. And again, it's up to the physician on how they want to approach and provide that palliative care. Hospice requires a prognosis of 6 months or less, so that it's expected that the patient will die within the next 6 months. Whereas palliative care, there's no life expectancy, and it's really just the patient indicating that they would like to change their focus of care rather than going to the hospital to receive care or going to the physician's office to receive care anytime they're feeling sick. They would instead they would rather stay at home, be comfortable, and not always seek immediate medical attention. Hospice is beyond curative therapies, so the patient often, again, that prognosis is less than 6 months. A lot of times they're maximized on their treatments. For instance, in heart failure, in order to qualify for hospice, they have to be, their treatment for heart failure has to be maximized, and yet they continue to fail. Their ejection fraction isn't doing so well, and they continue to be short of breath. Palliative care, they can pursue curative therapies if the patient desires them, so they're not necessarily limited in what therapies they can use. And then hospice, obviously, do not resuscitate is usually required, whereas palliative care DNR status is encouraged but not necessarily required. So now let's talk about what your facilities can do to partner with hospice agencies. I'm sure a number of you have already had patients in your facilities who are on hospice, but maybe you've asked yourself that question, like, what are our roles? Like, what should we be doing for these patients? How can we interact with these agencies? And as a hospice physician myself, I've seen a lot of great examples of facilities that really step up to the plate and really make a difference in that patient's end-of-life care. And I've also seen some not so great examples. And so my hope today is to share with you some means or some ways that you can participate in that end-of-life care for those patients that are in your facilities. So the care that's provided by the skilled nursing facilities and personal care homes include the continued watchful care that you would provide even if the patient were not on hospice. Make sure that you are continuing to do turning and repositioning. Just because a patient is on hospice doesn't mean we neglect them, but we should be continuing to provide wound treatments as ordered by the hospice team. If you've ever had a hospice patient with wounds, again, because of the hospice philosophy and the approach to care, the goal is not to heal that wound, but the goal is to treat that wound so that the patient is comfortable and that they are not deteriorating, that wound doesn't get worse, but really that it just that it's not painful, and the patient isn't uncomfortable from it. Also, obviously, the facility will continue to dispense medications. The hospice team is not always available, and even if the hospice patient were at home, the hospice team trains family members on how to administer medications, when to use certain medications, and everything. And so, similarly, it's the facilities who will be dispensing those medications to the patient. And then also, facilities can watch for signs and symptoms of decline and report those back to the hospice teams. One of our hospice nurses, when I asked her how facilities could support her in her role as a case manager, she said, "You are our eyes and ears, and you play an important role in the end-of-life care." And that's really true. As I mentioned before, I've seen facilities who really make a difference in providing that end-of-life care. They show a lot of compassion and a lot of interest in the patient, in the patient's families. They're very accommodating and understanding, and especially with difficult circumstances right now, and in COVID-19, where a lot of facilities are closed to the public, a lot of them do make exceptions for hospice patients in allowing family members, whether it's one at a time or two at a time, or whatever their limitations are, they do allow hospice patients to be visited by family members. Communication is key. So the better your facilities communicate with the hospice team, the better the two of you can provide that better, higher standard of quality care for that patient at end of life. And if you ever need guidance or have any questions or any concerns about the hospice patient or the situation, call the hospice agency. They're always available. They have a 24-hour service, on-call service. Most agencies do. I guess I can't speak for all of them, but you should be able to contact the hospice agency and receive either orders from a physician or guidance on how to administer the medications. And again, they're happy and willing to respond to your questions. So, who should I call? There are times where I'm sure the patient is declining or has a status change, and you're wondering, so what do I do? Who should I call? Do I call the attending? Do I call the case manager at the hospice? What should I do? And our recommendation is always to reach out to the case manager first, because the case manager can either reach out to the attending physician or a hospice physician or other team members, hospice team members, to get the support that patient needs. And so especially call the case manager with any changes or concerns with the patient. That manager can help manage the affairs at the time of death. So if the patient passes, notify the case manager, and if the case manager needs to come declare the time of death, or to declare the death, then they can do so. They're also available for emotional support for families. So if the family's visiting and they're having a hard time, or they're struggling, a lot of times family members, they deal with the dying process differently. Some people get very emotional and sad and depressed. Others get very angry and upset just at little things, and it's not really that they feel like you're doing a poor job. It's just they're already upset with the situation, and case managers are well trained on how to meet the needs of the family. Also, if you're having a hard time reaching the case manager, there is always the hospice on-call service that provides after-hours support. Call them and they can get you connected with the right people. And of course, last but not least, you can always reach out to the attending physician who needs to approve most orders unless he or she defers decision making to the hospice physician. So there are times where you may reach out to the case manager, and the case manager will reach out to the hospice physician for guidance. But before, if that patient has an attending physician, before the case manager makes any changes or implements those recommendations from the hospice physician, the case manager will often reach out to the attending physician to receive approval or an agreement that, yes, go ahead and implement those changes. Now, as mentioned before, some attending physicians, they serve in name only as an attending, and they defer all decision making to the hospice physician. So it just depends on how involved the attending physician wants to be. So managing symptoms in end-of-life care is very important, and oftentimes these hospice patients, they have a lot of different symptoms that can be difficult to manage. And so let's take some time to talk about the comfort care kit, which hospices provide, as well as symptoms and how to manage them. So comfort care kits are used by hospice agencies to target symptoms that may occur at any time during the end of life process. And these comfort care kits are not just convenient medications that someone just decided to pull out of a hat and say, hey, let's use these medications. There's actually guidelines developed by the National Coalition for Hospice and Palliative Care, what medications are appropriate and why and how much. And hospice agencies that are well accredited and well established follow those guidelines very closely. The comfort care kits consider conditions and syndromes that may occur based on terminal diagnosis and chronic illnesses. Typically, they will include medications to treat pain, anxiety, delirium, agitation, constipation, nausea and vomiting, excess secretions, and inflammatory syndromes. And so if you've never heard of a comfort care kit, or you've always wondered, like, where did this come from? Why do they choose these medications? Again, this is why, because the typical end-of-life management, these medications, in the typical end-of-life management, these medications will be used. So some typical medications that you'll find in a comfort care kit are morphine sulfate oral solution. So it's a concentrate that's 20 milligrams for every 1 milliliter, and that's used for pain or shortness of breath. Lorazepam, which is also an oral solution and is concentrated, and that's often used for anxiety or insomnia. Haloperidol oral solution, another concentrate, is used for nausea, and this one I use it a lot for a lot of different things, but nausea, vomiting, agitation, or restlessness, it's good for any of those things. Dexamethasone tablets are often there for inflammation or COPD related shortness of breath, and also for cancer pain. Steroids help shrink down the cancer, the tumors, and can help with any inflammation that's caused by the cancer. Viscoidal suppositories for constipation, acetaminophen suppositories for fevers or mild pain, and then hyoscyamine can be used, or Levsin can be used for excessive secretions. There are other medications that you can see in a comfort care kit. Sometimes there's atropine drops or scopolamine patches, other suppositories for constipation, but these are ones that most agencies use, and again, because The national organizations have done research and shown that these medications are very beneficial. So as far as treating pain control, the goals in hospice are mostly driven by the patient or the family. Um, we want to make that patient comfortable. We want the family not to worry that the patient is in pain or discomfort. And so oftentimes if they are complaining that they're uncomfortable or that they're in pain, then we will provide the pain medication or increase the pain medication if they're using it and it's not effective. Keeping in mind, however, that a 0 out of 10 pain is not always realistic or optimal, right? If we give that patient an excessive amount of morphine, then they'll be doing a lot of sleeping. And most families during end-of-life care want to still talk to that family member and reminisce and tell them that they love them and they appreciate them and they're so grateful for the time that they've spent together. Really, that time on hospice is an opportunity for these families. So we don't want to over medicate the patient. Treat their pain so that they're comfortable, but again, 0 out of 10 pain is not always ideal. Use appropriate medications for the type of pain. So even though the comfort care kit uses morphine, it's not there for all different types of pain. Asking, is this a central pain? Is this a peripheral pain? Is it related to cancer? Is it superficial on the skin, or is it deep, in the organs? That can kind of help drive what medication is used to treat the pain. And then I like to include this because there's a lot of misconceptions, as there is with morphine, there is about methadone as well. And with our patients that have metastatic cancer pain, methadone is a very long-acting opiate. It's approved for treatment of pain. It's not just for drug addicts, but it's approved for treatment of pain as a long-acting opiate. And it particularly does an excellent job of treating metastatic pain, especially metastatic cancer that has gone to the bones. And that's just because of its mechanism of action, the way that it interacts with the mu receptors and other receptors in the body. Methadone is very effective for that. Additionally, we don't always think about steroids as to use for treatment of pain, or at least a lot of nursing staff don't always think of that for treatment of pain. But really, dexamethasone is a great resource for treating that metastatic cancer pain or any cancer pain, because it helps reduce the inflammation that cancer creates. And it also helps reduce the swelling of the tumor. Retrospective analyses have demonstrated no association between opioid or sedative use and survival time. And here's one study that talks about opioid use at end of life and survival in a hospital at home unit. And basically what they found was that there was no statistical significance between patients that received morphine and patients that did not receive morphine at end of life. There's no statistical difference between their length of life. So using morphine does not shorten the patient's life. And that's a misconception that a lot of people have. They are afraid of using morphine because they say, if I give them morphine, they're going to die. And that's not true. The research doesn't support that. What morphine does allow for is it makes the patient comfortable. Again, we're using morphine at a low dose. It's not at anywhere near a level of medication that would cause a person to die. If you're using it as prescribed in the comfort care kit, or if the patient's been using it for a while and the physician is increasing the doses to 10 milligrams, 15 milligrams, 20 milligrams, as long as it's done in a titrating manner and appropriately, you do not go anywhere near the level of morphine that would cause the patient to die. So I just wanted to reinforce that idea and help medical staff who's providing that care to recognize that morphine does not take the patient's life. It helps them to be comfortable at the end of life. So dyspnea, there are a number of things that can cause dyspnea at end of life. The dying process can cause a lot of anxiety for the patient. Sometimes the patient is dying from airway diseases or pleural fluid retention. Shortness of breath can also come from blood disorders, if they're anemic, or ascites, pain, secretions, cardiac disease, muscle weakness. Any of these things can cause shortness of breath. So recognizing that there are multiple causes, you don't always have to use a medication to treat dyspnea. So there are non-pharmacological treatments that you can try first. If you recognize that there is an underlying cause, such as anxiety, you can provide non-pharmacologic means to help the patient kind of lower their anxiety, doing the deep, slow breathing, talking with them, sitting with them, spending time with them will help decrease their anxiety. You can also do improve air circulation. The feeling, putting oxygen on their nose gives the patient a feeling of relief and helps comfort them. Even if they don't need oxygen, it's comforting to feel that air blowing, and can also help relieve the anxiety. Repositioning them, spending that time to get them in a more comfortable position can also help with shortness of breath. If they are having problems with secretions, sitting them up at a angle will help. A lot of times with cardiac diseases, laying flat is very uncomfortable, right? They have that pleural fluid retention on their lungs. So repositioning them, having them sit up helps them feel more comfortable. And working on relaxation techniques. Any of these things can help with shortness of breath. Morphine we use to treat shortness of breath because it increases the vasodilation in the lungs, and that improves the ventilation perfusion ratio. So morphine outside of hospice is also used in the hospital for patients that are having a myocardial infarction, a heart attack. And the reason why it's used there, because it helps dilate the blood vessels around the heart and helps with in the lungs as well with the ventilation perfusion ratio. And so we use morphine in hospice for the same reason. Bronchodilators, obviously, if the patient is short of breath and is wheezing, then using bronchodilators like albuterol is very beneficial. And then sometimes, especially in the heart failure patients, using diuretics will really go a long way for helping their shortness of breath because of the lung congestion. Or if they have fluid on the lungs because of cancer, using that diuretic to help get that fluid off the lungs will make them feel a lot more comfortable. Nausea and vomiting is another symptom that a lot of patients in end of life will experience, and treatment selection is based on the pathway that is causing the nausea or the vomiting. So chemoreceptor trigger zone, if the patient is a cancer patient and was receiving chemotherapy, medications that work would be the haloperidol that's in the Comfort Care kit, thorazine or prochlorpromazine, promethazine, chlorpromazine. Any of those will will help with the chemoreceptor trigger zone. Ondansetron only works if the patient is receiving chemotherapy. So oftentimes after they stop receiving chemotherapy, or if they've had chemotherapy, then the Zofran, the ondansetron, will be beneficial. Whereas if they did not receive chemotherapy, it's not very beneficial. If they are nauseous because of a disruption in their vestibular system, then meclizine or scopolamine patch or glycopyrrolate are all great medications to help with that. If they're nauseous or feeling sick to their stomach because of anxiety, then benzos or antihistamine will help calm them down and help with the nausea that way. Or if they have gastric stasis or paresis, then metoclopramide or erythromycin can help with that. And here are my references, and I thank you for your kind attention.